All right. Can everybody see my slide? Okay, wonderful. So I'll be talking about colon cancer screening, update in some guidelines. So I'll review some recent trends in colon cancer incidence. We'll talk about the new updated guidelines. We'll talk about what we expect to find in this younger age group that's been included, and perhaps give you some ideas about current and future options for colon cancer screening and some take-home points. So as we know, back in 2016, the recommendations were to screen adults between the ages of 50 and 75 who were average risk and using a variety of modalities for colorectal cancer screening. And we were making wonderful strides in trying to achieve these goals. And then in 2018, the American Cancer Society gave a qualified recommendation to lower the screening age to start at 45 for average risk men and women. And this includes all racial and ethnic groups. And the main reason was this rising incidence in colon as well as rectal cancer in individuals younger than 50. And their guideline was informed by modeling studies using two of three popular CISNET models. And this is what was reported in their publication and in their guideline. So on the bottom of the screen, you can see a nice declining trend for men and women 50 and older in the US for the last 15 years. And this is exactly what we hope to achieve. Most of this, we think, is due to the effect of screening in this age group. However, on the top part of this slide, the graph that you see represents cancer incidence in men and women between the ages of 20 to 49. And you can see the curve has been relatively flat over time. However, over the last 10 or 15 years, we see an uptick in that incidence rate such that it appears to have gone up by about twofold. And this is truly the trend that was concerning. And then when you look at the colon cancer incidence in the US, broken down by age at diagnosis, again, you can see that one of the biggest risk factors for colon cancer is age. The risk of cancer increases with increasing age, but the question is, where is the minimum threshold where we should start screening? Largely, that threshold is thought to be about 30 per 100,000 incidents. Once it crosses that threshold, screening is largely considered effective and cost effective. And you can see in the age group 45 to 49, we meet and exceed that threshold. Not only that, if you see the current incidence in 50 and older, there's a large bump starting at 50. This suggests that these were cancers that perhaps would have been detectable earlier than 50, but because we concentrate our screening 50 and older, so we have this big bump, which we could address by screening earlier. The other interesting temporal changes we've seen is that the annual percentage change for cancers in the older age groups has been on the decline or in the negative category, which is good news. But for individuals that are younger than 50, that change has been in the positive, meaning we've seen a net increase in cancer incidence over time. And this increase is largely in non-Hispanic whites. And you can see the breakdown in other groups. To the point that this is described as a birth cohort effect, which seems to suggest that every cohort born after 1965 compared to cohorts born in 1940s carries an increased lifetime risk of colorectal cancer. So this risk isn't just at a certain age, but carries with them throughout their life. So the question is, what can we do to mitigate this risk? Also, one might say that a lot of the rising incidence we see might be because we're doing a lot more colonoscopy. We see a lot more patients that come through our clinics or hospitals, and they're just getting scoped more, and we're finding more cancers incidentally. So this study argues against that. And so this study shows that the recent increase in incidence is not just in early stage cancers that arguably we would find had we waited to screen somebody at 50, but we're finding that this rise is in cancers of all stages, meaning we're finding increased number of regional as well as distal spread, cancers with distal spread early on. So this indeed makes an argument for screening earlier. So the recent changes, starting with the ACG clinical guidelines in 2021, and in this guideline, we gave a qualified recommendation that cancer screening should start at age 45 to 49, again, to address this rising trend of increasing incidence of not just cancers, but also precancerous lesions. And we also recommended either colonoscopy or a stool-based fecal immunochemical test as primary screening modalities to begin with. And an important guideline recommendation relevant to our current practices is the C5 guideline. And this is for all New York City healthcare providers. Again, encouraging us to start screening at age 45 for average risk individuals. And the options are either colonoscopy every 10 years, a stool-based test, such as a fecal immunochemical test every year, a high sensitivity GWAC fecal occult plus test annually, or the multi-target stool DNA test every 3 years. Being mindful that these tests, if they're positive or abnormal, they need to be followed up with a colonoscopy. So making sure that system is in place to ensure that happens. And individuals with family or history or increased risk may need screening beginning even earlier than 45, usually 10 years before the earliest cancer in a first-degree relative. The U.S. Preventive Services Task Force also updated its recommendations and now gives screening individuals who are average risk starting at age 45 a grade B recommendation, which means that there's moderate certainty that there's at least a moderate net benefit. And the recommended strategies are very similar to what I outlined, but include a few other options to pick from. Again, generally, things that get an A or B recommendation are usually covered by Medicaid, Medicare, and most payers follow. So very quickly, this will become the standard of care. Now, one has to think about the benefits of screening at an earlier age, and which is reducing incidence in this younger group and also boosting screening in those 50 to 55. But weigh it against the harms. Do we have enough access? What resources will we need? And will we worsen disparities by crowding out the capacity that we have, which is not great across the US? So again, it helps to understand what benefit we hope to gain by screening people earlier. So in this modeling scenario, if we were to start screening at age 45 compared to screening at age 50, the additional colon cancer cases averted are about 3 per 1,000 individuals screened. However, it's not without harms. The additional complications by starting screening at age 45 range from about 0.2 to 2 per 1,000. So again, it ends up being a trade-off, and sometimes this balance is very, very close. And then there's no question that this will add burden to our healthcare system. And here you see that these are the additional tests if we started screening at age 45. And you can see the number of additional colonoscopies and other tests that would be required per 1,000 individuals screened. So think about your healthcare systems, your practice settings, and do you have the capacity or can you build it to absorb this increased demand? Now, how well are we doing with screening? And again, Felice and Joe will talk more about this. But as you know, screening rates aren't uniform across the US, and every state somewhat is a checkerboard of screening rates. The Northeast tends to do really well. In New York, overall, screening rates are about 72%. But in other places, such as down in Laredo, Texas, screening rates are between 17 and 37%. overall in the US, we're at 64%. And by race, whites have the highest screening rates, followed by African Americans, and Asians are lower. And now we've added another 21 million adults in the US, ages 40 to 49. So we've unleashed this tsunami on top of a screening checkerboard that we were already trying hard to achieve. So we must be very, very careful and strategize how we're going to address this burden. So the pressing questions are, what is the prevalence of neoplasia in this newer, younger group? And how will we screen everybody who's eligible? So what we do know is that risk of adenomas and cancers increases with age. But what we don't know is the impact of lowering the screening age for individuals that are younger. And we certainly don't have any colon cancer mortality data on this younger age group as yet. What we have is prevalence of neoplasia. These are advanced adenomas or cancers. And for individuals 40 to 49, and again, these were individuals with a family history, you can see that the rates of cancer or advanced neoplasia are about half what we would find in individuals 50 to 66, again, suggesting they're a lower risk group. This one study from the New Hampshire colon registry has more recent data, and they compared individuals that had a diagnostic colonoscopy for indications that did not make them high risk, such as abdominal pain or constipation, to individuals 50 to 54 undergoing screening. And again, they report very similar yield of colorectal neoplasia and cancer, suggesting we might find rates similar to what we see in 50 to 54, but lower than what we see in 50 to 75. So there will be some impact. The question is how much. The next question is, how will we screen everyone who's eligible? And the two components there are who and how. So these are data that you all have probably seen published. These are screening rates in New York City, and great strides have been made over decades of extremely hard work. Where overall screening rates have gone up tremendously at 69% currently, and great strides have been made to reduce and eliminate disparities. However, if you look at prevalence of timely colonoscopy by different neighborhoods, you can still see that it looks like that same checkerboard of the US, where some areas tend to do better than others. So truly our challenge is to understand where these deficiencies or disparities are and how we might address them. There are very many screening options other than a colonoscopy. I don't expect you to read all the details of this table. I've provided you a reference, but the idea is there's more than one screening test. And at the end of the day, the best screening test is the one that gets done. So healthcare systems really need to think about being creative in offering maybe more than one screening option. And here's some that are highlighted. And then again, our emphasis should be on improving adherence. This is, again, a complicated network of different interventions that we can apply, and also who they're targeted towards. And sometimes we need multifaceted, multi-level approaches targeting patients, providers, the organization as a whole, and the community. Organized screening works. So this was demonstrated by Kaiser Permanente's model. This is real-world data where they put in a proactive outreach program. It's primarily based on FIT and then colonoscopy. But you can see that over 15 years, their colon cancer screening adherence went up by 44%, and the incidence and CRC mortality were reduced by 24 percentage points and 52 percentage points during that same time period, showing impressive evidence of improved screening adherence and reductions in incidence and mortality. And outreach works. So if there's one message I can give you is think about outreach efforts. It doesn't matter what test you use, but here's a study that looked at usual care versus colonoscopy outreach. They got a big bump in screening adherence. And then when it was FIT outreach, even a bigger bump. So again, these data might differ for different areas, but outreach is truly the message here. and in the last minute, what the future might hold. We are now at the cusp where blood-based testing for colon cancer is becoming a reality. And it used to be we could only detect signals with late-stage cancers in blood. Well, new technology with cell-free DNA, proteomics, and metabolomic approaches, along with AI and machine learning, have enabled us to actually detect cancers at a much earlier stage. So this makes the field of blood-based cancer very promising. In fact, Medicare has set a bar of the blood test, how they would like it to perform for approval process. And the requirements are that a blood-based test needs to be 74% sensitive or higher, specificity of 90% or higher, and FDA approval and guideline approval. And just to give you a flavor, there's about 6 or 7 different tests that are either finishing their pivotal large-scale prospective studies or have actually completed their studies and are looking at getting their tests approved. So my prediction is in the next year or so, this landscape will drastically change and we'll have some blood-based FDA-approved options. So in summary, there's a rising trend of advanced neoplasia and cancer in 45 to 49-year-olds. And the prevalence rates are lower than that for 50 or 55-year-olds, but still enough that we need to start screening. With that, we need to be looking at our approaches with emphasis on adherence. And there's some promising tests up and coming to help us with these efforts. And with that, I will stop sharing and I will hand it over to Felice for her talk. Thank you so much.
Wonderful. Can you hear me?
Yes.
Okay, perfect. Thank you so much, Asma. That was a wonderful, opening for this really important time, actually, in anyone's practice and really in our society in terms of trying to make a major impact in colon cancer. So the new guidelines, congratulations to you on those, because they really help lead the charge for all of us. So what I'm going to try to talk about today has to do with how can we now try to think about all of these people that we know that are out there, these 45 to 49-year-olds that we started to increase in this group. How can we now reach that group of patients, and what are the challenges of implementing these new guidelines? So I took this slide from Asma because it was fantastic. And when I was looking to try to just create one and I saw her presentation, I said, why am I going to do that? This is a perfect slide. And basically, when I see something like this, a slide like this, and the sort of initiative that we have done, you know what? We need to congratulate ourselves. We've done great strides in increasing colorectal cancer awareness and in screening, but the reality is, the harsh reality is, we're not there. And now we are adding to this pile a huge number of patients that we're going to try to embrace in colon cancer screening efforts. So are we going to be able to do this? What do we actually need to do to get there? So 45 is the new 50. That sort of slogan, for those of us that are in this world, you see them all over the place, right? You see it from ACG, you see it from Screen for Life, you see it from ASGE, from United States Preventative Service Task Force, obviously. This is really the message that we're trying to just push out to people to make them aware of this change. But there are a lot of barriers to this actually happening, and there are some facilitators as well. And I'm going to just try to sort of embrace the conversation now a little bit on what that is. So from the standpoint of barriers, that's the left side of the slide. You can see here, actually, there's a lot more barriers than there are facilitators, and that's kind of a scary thing when we think about this type of programmatic effort. So in terms of barriers, there were policy, sort of barriers. Now we're starting to push policy out with regards to promoting the colorectal cancer screening this younger age group. But there are social context issues that are going on. There are beliefs about gender and cancer and medicine and religion that 45 to 50-year-olds might have that are different than patients over the age of 50. And there are organizational and health services issues. For instance, the endoscopy units. We're talking about a huge potential burden with a lot of work overload that endoscopy units may not be able to handle if we're going to try to say that all these patients should be done by colorectal cancer screening. From the standpoint of primary care clinics, they also have work overload. They may have an insufficient infrastructure to be able to handle even talking to patients about this additional time. For those of us that are, in the primary care arena, you could recognize that there could be lack of personnel and lack of infrastructure to be able to do this. And there could be resistance to new programs because there's just so much that's already on their plate in terms of screening. And now you're adding another whole load to them. What about the hospitals? Is there a long waiting times to actually get procedures? Is there a long distance to health services for these individuals to actually bring them in? And then interpersonal, it's no different than for patients that were 50 and older, but there are fears of colonoscopy, and peers that may be younger may have additional fears for procedures. And specifically, there could be things that are related on individual level, like, for instance, lack of colorectal cancer awareness, fear of the colonoscopy, fear of the findings that one might have, or fear of a serious illness, embarrassment of getting a colonoscopy, lack of time. Now, that might be a very, very large issue for this younger population. I'll go into that in a little bit greater depth, but also just in terms of distrust of medical services. I mean, certainly we saw a lot of that with relationship to vaccination status. There might be people that might, be reluctant to want to do this because just a fear of actually going for a procedure. In terms of facilitators, things that actually make a big difference, a huge difference, obviously, is good experiences with the health service use. A good doctor-patient relationship is key, and great doctor communication skills is fantastic in terms of making patients aware of these things and endorsing it and supporting them in going in, getting the job done. So when we talk about these younger patients, what are the challenges of implementation of something like this? Well, older patients recognize that they may be at risk for getting cancer. I mean, it's not an unreasonable thing that you can. I'm just got to block it, some kind of thing on my screen. I apologize. So it's not unreasonable for patients that are older to believe that they are at risk for cancer. But when you start to decrease the age of cancer and start talking that message, young people just do not believe that they are at risk for cancer. And there might be still a lack of awareness. The other thing in this younger group is that they are busy. We're now talking about people that are actively working. Maybe they may be at the top of their game in terms of where they are in their job and in the workplace. They could have children at home that are still in school. They might not have insurance. Younger people think differently about having insurance. They might not, because they don't feel that they have other medical problems, they might not believe that they have insurance at all. There are certainly obviously other people that are underinsured. And then, like for anyone, fear of prep, fear of the procedure. Now, another thing that's very interesting is that younger people just don't have primary care doctors. I can't tell you how many people within the 45 to 49 age group that say that they have never had a primary care doctor since their pediatrician. And the reason for that is they're well, or seemingly well. They don't think that they actually need to go to the physician, and they don't have a primary care doctor. And then the same reason why they're so busy is they might not actually have people that can escort them. As people get older, they may have their children that can escort them, and things of that nature. But when people are younger, many times the same people that would take them home are the people that are actually at work themselves. So it could be very challenging for them to actually even be able to get an escort back. Now let's look at this, statistic. This is actually quite interesting. The percentage of adults age greater than 18 who've seen or talked to a doctor or a healthcare professional about their own health in the past 12 months. Well, when you look at this different category of patients, when you start looking at those 40 to 49-year-olds, look at that drop off. There is a significant drop off between 50-year-olds and patients in their mid 40s who've even talked to a doctor in the past year. And we've spoken about how important that relationship is. And so if they're not even seeing a physician, that group that might actually encourage them, tell them about the importance of screening, may not actually be in their lives. And that could be a major issue in terms of getting a message out for that age population. Now, there's also something interesting about this generation. They're not the same group as the 50-year-olds. And so, I just broke this down into, the common terminology of this age group. And so, there's a difference between Generation Z, Generation Y, Generation X. I'm not going to tell you which generation I'm in, but I'm definitely not in the Alpha. I'm not in the Z. I'm not in the Y. So there you go. You know where I lay. But when we talk about these different generations, they approach things in a different way. And so, some of these individuals are skeptical about things, questioning things. And so just the same way the way that they approach the workforce, they might have a different impression of how they approach the workforce. It's the same way that they approach things like getting screened or seeing a doctor, that might be different as well. So the mandate is the conversation is about starting at age 45. Individuals with an average risk of colorectal cancer should undergo regular screening. And this is the other thing that Asma actually spoke about with one of 6 different tests. And the thing that I think that we have to truly, truly stress with this group is depending on patient preference and test availability. And, the recommendations that have been put out do not prioritize one test over another. And I think that is going to be really an important issue for us to grapple with this group of individuals that may be skeptical, that may not have time, that may not have someone to take them home. We have to look at all of the options for them in order to get them screened. So the other thing that, I sort of was alluding to is that people believe nobody in their 20s, 30s, or 40s gets colorectal cancer, right? Well, that's wrong. That's wrong. And we don't really know why. But there has been a very frightening increase risk of colorectal cancer in younger individuals. And specifically, the other thing that I'm sort of talking to here also is rectal cancer that we've seen even in people in their 20s. We don't know why. Sedentary lifestyle, high fat diets, processed meats, environmental factors. The reality is we just don't know what this increased incidence is related to. Some of this was initially seen. This is one of the original articles that was put out. This is Rebecca Siegel that was looking at colorectal cancer incidence patterns in the United States from 74 to 2013. And, here you can see in these different birth cohorts, just sort of what Asma was alluding to was this increased incidence of colorectal cancer. But actually look at this in terms of rectal cancer. This is different than just colorectal cancer, but actually an increased incidence, a rise of rectal cancer in these very young cohort of patients. So what do these Gen Xers and millennials need to know? What they need to know is that they need to communicate with their physician about things like rectal bleeding, unusual stools, change in bowel habits, low energy or tiredness. And really what I think, in addition to just the message about colorectal cancer screening should now begin at 45, the other thing that we have to do is not assume anything and if these individuals, even though they're young, present with any of these types of symptoms, they need to speak to their physician and require an investigation for the symptomatology because it could be colorectal cancer. Now, what are some strategies to implement that might improve organized screening? Asma spoke to the fact that organized screening absolutely does work. Well, some things that can work are patient navigators. These are extremely helpful in being able to get the work out and navigate patients through the system, whether with regards to getting their tests done or understanding the prep instruction. Patient reminders in busy people like the young, they need reminders, and it needs to come out in multiple different ways. It needs to come out on their phones, text messages, whichever way you can't just reach out to them the normal way. They might not be seeing their doctors, as I said. Now, clinician interventions are important, provider recommendations are important, giving clinical decision support tools are extremely important, but reminding patients, especially young patients, is extraordinarily important, and we need to reach out to them through things like their phones if it's going to be from the physicians themselves. So improving cancer screening rates, there's essentially 4 essentials that you need to think about. One is making the recommendation. We have to be clear that screening is important and ask our patients about their needs and their preferences, especially in this young generation. You need to get into their head and understand what they will do and understand what they will accept. You need to involve, in the practice, you need to involve your staff to make screening more effective. You can't do this alone. So it has to be a whole group effort. Everyone on the team needs to talk about getting the message out. The younger person, the receptionist, the doctor, all the people in the team need to be creative in supporting and following the policy. You need to be persistent with these young people. Simply tracking a system will help you follow up as needed, but you may need to remind patients several times before they follow through just because of their busy lifestyle. And in a practice setting, you need to measure your practice. Seeing screening rates improve can be very rewarding for a team, but if you never measure it, you have no idea what you're doing. And then lastly, it's about getting the word out. I can tell you all of our organizations are trying to do this. The ACG is trying to do this. As I said, all the organizations are putting out fabulous things to try to explain that there are one-step tests, as Asma described, and two-step tests, whether or not someone goes for colonoscopy or goes for things like stool-based test and then requires another test done if a finding is found. We need to offer all of the screening options to patients and then talk to your doctor about the best test that's for you. And just like Sid Whittemore, one of my, my greatest advocate and someone who's been a great mentor for me, the best test is the one that gets done, whether it be FIT tests, whether it be stool-based tests, whether it be colonoscopy. We need to talk to young patients about things that are convenient to them. And then lastly, we need to use actually other patients that have unfortunately have succumbed to colon cancer that might actually ring true with patients. We all know that the Black Panther star Chadwick Boseman died of colorectal cancer, and it's a terrible thing to see that happen, but we need to get the word out that this can happen to young patients. And the Kirk Effect, she spoke about the fact that her husband had died at the age of 42 of colorectal cancer. Obviously, she made a huge impact in getting people to go for their screening colonoscopy by doing her on-air colonoscopy, but we need to use the celebrity status to also help us to get the message out to reach this new patient population. Thank you so much for your time, and I look forward to your questions.
Thank you so much, Felice. That really, brought everything home and started a really practical discussion. So if you want to respond to some comments in the chat box, to the audience, please keep posting your questions in the chat box. I'm sure there'll be many more as we go to our final speaker, Joe Ravenel. And after that, we'll have time for discussion. So I'm handing it over to Dr. Joe Ravenel. Take it away.
Thank you so much, Asma, and thank you, Felice, for that for those wonderful presentations. So my goal is to talk about achieving health equity in colorectal cancer screening. And so what I hope to talk about today is first defining equity with regard to colorectal cancer screening, examining equity as the guiding principle for the C5 coalition, reviewing New York City CRC screening data, the most recent data that we have from C5, and to discuss a framework for using evidence-based interventions to achieve CRC screening equity. So I just want to go over some basic definitions that I'm sure this audience is well aware of, but for a long time, we have thought about health disparities, which are defined as significant differences between one population and another in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates. And this is kind of official government definition, or the policy definition that was adopted in 2000. But I think more recently, we all realize that we can't just focus on the numbers per se. And so I think that we have more recently moved to thinking about health equity. And this definition comes from the Robert Wood Johnson Foundation, which I believe really captures what we're all here to do. Health equity means that everyone has a fair and just opportunity to be healthier. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. And really, what health equity does is it takes the discussion about health disparities beyond the numbers and to really talk about what are the root causes behind the disparities that we see. And so we think it's really important for us to adopt this notion of health equity so that we can actually address those disparities. So speaking of disparities, colorectal cancer is unfortunately a perfect example of where we see significant disparities. And this data shows back in 2003, there were significant disparities here in New York City, where we see that there were different screening rates by race. Essentially, where in the orange is the orange line is white, the dotted line is overall, the yellow line is Hispanic or Latino, the gray line is Black, and the light blue line is Asian / Pacific Islander, which were the designations at that time. What we see is there are significant disparities in screening, which also translated to disparities in mortality as well. And so this really was one of the driving factors for the establishment of C5, and what we see over the years after the establishment of C5 and really the prioritization of colorectal cancer as a focus of health equity here in New York City. We see that over the years we have closed the gap for several groups, but there's still work to be done, particularly in our Asian communities. So as I mentioned, health equity has always been central to the C5 mission, going back to when it was established in 2003. The C5 mission is to help New York City attain colorectal cancer control goals through advocacy, resource development, and policy initiatives. And the central goal has always been to strive for universal colorectal cancer screening for all eligible New Yorkers. At the time, it was age 50 and older. And at the time, we believed that colonoscopy really was the gold standard, and that's what we should strive for. But as our two previous speakers have noted, we've adopted a more inclusive approach, really touted by one of our greatest champions, Dr. Sid Winnower, which is the best test is the one that gets done. And so colonoscopy, of course, we believe is an important test, but there are multiple other modalities by which we can look to achieve health equity. But it's important to keep in mind that any screening test that we do that is not colonoscopy, if it is abnormal, it must be followed up with a colonoscopy in order for screening to be considered completed. So I just want to review some colorectal cancer data that we have for New York City. And so this shows over here is our key. Basically, as we go from light blue to dark blue, essentially higher colorectal cancer mortality rates per 100,000 people. Just want to bring your attention to the benchmarks for the death rate for the U.S. overall is 14 per 100,000. For New York City overall, it's 12.6 per 100,000. But what we can see in this graph is even though the overall rate is 12.6 in New York City, that there is variation. Variation within different neighborhoods, and unfortunately, many of the darker areas do overlay with where we see a higher proportion of communities of color, particularly here in Staten Island, as well as in northern Manhattan, central Harlem, and areas of Brooklyn as well. This map shows death rates for different neighborhoods, and these numbers represent the UHF codes. But essentially, we see as we go from brown to this turquoise color that that the death rate increases as we change colors. But what this map also shows is the concentration of federally qualified health centers within these various neighborhoods. And I think the reason for us to show this is for us to think, as we think about addressing some of the inequities that we see, particularly when it comes to our uninsured and underinsured New Yorkers. Federally qualified health centers can be incredibly powerful partners in helping us to address issues of inequity when it comes to colorectal cancer screening. So this shows in a tabular form colorectal cancer screening rates for some of the federally qualified health centers here in New York City. And this goes from lowest screening rates to highest screening rates. And this is a selected number. And over here is the name of the FQHC, and over here is the neighborhood. And again, we can see that in some of the places where we see some of the lowest screening rates are also those places that tend to overlay with places in New York City where we see a higher proportion of minority communities. Here, what is depicted is the fact that similar to data that Dr. Schulman shared, we see that some of the lower screening rates are in the newly eligible, age 40 to 49. But we also see that there really is only one group in which we have achieved 80%, and that's in the 70 to 74 group. And we at C5 have always looked to align with the efforts of the National Colorectal Cancer Roundtable. You may recall that we had a very powerful campaign, 80% by 2018 screened. Now that 2018 has passed, we've adopted a new priority, which is 80% in every community. And that not only includes geographic communities, but community can be defined in many different ways. And so what we want to aim for is to try to expand this group of people who have achieved 80% screening really to everyone who is screening eligible. But I think we really do want to try to focus on these groups where the screening rates are considerably lower than the rate overall in New York City, but considerably below the 80% target. And so certainly focusing on the newly eligible 40 to age 49, and then still in this 50 to 54 group, there's still much work to be done. We actually noticed this trend about a decade ago when we looked to increase screening among Black men, and what we found was here in New York City that Black men were much less likely to be screened before the age of 65 compared to other groups. And so we really focused on an intervention that would include community-based organizations such as churches and barbershops to try to reach that younger group of screening eligible people. And we tried to take into account many of the social determinants of health by essentially placing a patient navigator in the communities where these men work, live, and play. And we found in a randomized trial that putting a navigator in those places outside of the four walls of our clinical settings was about twice as effective at helping these men to get screened compared to only a referral from their doctors. And so we were able to demonstrate that the partnership between communities and clinical teams was really key for addressing the issue of equity. So I want to end on just looking at a framework as we look to achieve equity going forward. This comes from a colleague, Dr. Chaik Dubeni, who's done lots of terrific work with regard to colorectal cancer equity. And here we see that just as my two co-presenters have already presented, that it really does take a multifaceted, multi-level strategy for achieving equity. And certainly policy is incredibly key to that. I think that the adoption of the new screening age, I think, is actually a really critical policy that I believe has implications for, in particular, Black Americans who we know often suffer from severe forms of colorectal cancer at an earlier age. And so hopefully by lowering the screening age for everyone, it gives us the opportunity to reach everyone, including those who are at highest risk at an earlier point for early detection and intervention. But when we talk about policies and programs, we're talking about federal payers, certainly increasing access, removing financial barriers to screening, colonoscopy, as well as follow-up, including biopsy and other follow-up testing. Guidelines, as I mentioned, are absolutely key. But making sure that we pay special attention to those high-risk groups, and then public-private partnerships to try to increase community capacity to achieve health equity. And so, in addition to policy, there are also healthcare community-linked implementation strategies that include both healthcare-based strategies as well as community-level strategies. And what we see here is there are multiple levels here, patient-level strategies, provider-level strategies, and then programmatic strategies that we can adopt that really have a focus on increasing utilization and access of screening tests. But we can't forget community-level strategies, because we know that for many of people who are at highest risk, they are not. We can't just depend on face-to-face clinical strategies, because many of those people are not represented in our clinical populations. And so, community-based strategies, community outreach, and partnerships for timely access really are a critical strategy to help get more people into our clinical settings to really take advantage of the clinical innovations and the life-saving technology that we know screening is. And so we are extremely optimistic that if we can put some of the practices that we've heard about today, if we can implement those strategies, that we can move towards health equity in colorectal cancer screening. So I'm going to stop sharing, and I'm going to turn things back over to Ausma. And if you can please enter any questions you have in the chat. And thank you for your time and attention.
Thank you so much, Joe. Excellent talk, and really brought all the points home about the bringing in the younger group, but then also keeping health equity at the center. So there's a lot of activity in the chat, and I'll bring out some theme questions and address them to both of you. So Felice, given this younger group, the the audience thought, why don't we meet them where they're at? And some suggestions brought up were social media campaigns, cell phones. What do you think are some practical, viable strategies, say, if you were to do this next month, that you would approach?
Yeah, so I 100% agree. So the old strategies of how to reach out with this group, they can work a little bit, but they are not going to work the way that we would like them to. So, commercials on television, it's not that they don't watch television, but they're on Netflix. It's just a different group of people, and they are on, like everyone is saying, social media. So they are watching social media, and influencers make a huge difference. And I would say, in terms of social media, hooking up with influencers that may go for their colonoscopy and will talk about their experience, or perhaps other family members that they've had that have had colorectal cancer. This age population, watches that. But even campaigns that link in some way to their phone, to text messages. I mean, there were campaigns that I saw that were brilliant in Australia that had to do with trying to get people to do a screening for skin cancer. And they would, as they went onto the beach, people went in there, they got a text message about knowing to get screened for skin cancer. We have to be really innovative about this group, and because they're smart, they're active, they're educated, they want to do the right thing, but there's just a different way to actually get to them than just through their PCP and normal advertising campaigns. So I agree completely.
Great. Joe, anything to add to Felice for sure? And then the additional question for you, you showed some very compelling data for different FHCs. So can you outline some of the barriers that are preventing us from reaching those rates? And are they specific to a certain, FHC? Do we need multiple approaches? Or is there something that can be somewhat broad and all-encompassing?
Great question. As I mentioned, I believe FQHCs are incredibly important partners in helping us to achieve health equity when it comes to colorectal cancer screening. Certainly, some of those rates, pretty much all of those rates are below where we ideally would like for them to be. I do believe that there are a couple of common barriers, and some of those are ones that Felice mentioned. One is that the patients that we often see at those settings are incredibly busy people, and often don't have the luxury of taking a day off of work in order to be able to tend to either a colonoscopy prep or even to properly complete a fit test. I think of those two options, probably for people who don't have the ability to take off of work, the fit test probably provides a little bit more of an accessible test. But one thing we know from much of our work is that even a fit test often requires navigation in order for the test to be done properly. And a stool-based test that is not done properly is basically not useful. And so I think thinking about how we can fortify the infrastructure of some of our community health centers to include navigation, not just colonoscopy, but also navigation for properly completing the fit test, can be one way that we can try to reach more of the patients who attend these centers.
Great, well said. Navigation is truly the way to go. So for clinics and healthcare systems, if you're thinking of what is the one high yield thing, it's clearly I think navigation came across. And then and this might be something that Felice, both you and Joe might be able to address. Do you think that the screening message needs to be targeted to different, not just age groups, but also to different populations? And does that targeting mean different languages, different media, or how would you approach it?
Oh, yeah. So, I mean, thinking that everyone is reached by having a messaging in English is just ridiculous, right? So I know the Department of Health, we are working with partners that totally understand this. And there is some expense related to this, but if we truly want to reach all the individuals that this is important to reach, we have to speak their language and we have to make sure that our materials are in their language and even the messaging might change, right? So different groups think differently about interventions. And like I said, we have to get into their head. Now, the reality is this, a lot of those different sort of understandings, whether it's different ethnicities, we probably did a lot of that work in the 50 and older. So we have a little bit of a sense of that. I think the main difference is things that, both all of us have sort of highlighted is where should the message come from? So in younger people, we pushed before with gynecologists, but we should push more with our gynecological colleagues because women are still at that age absolutely going to their OB-GYNs. And so they are still engaged with them. If they might not see a PCP, that might be their PCP. You should go to them. There should be outreach efforts that might happen in children's schools because their kids are going to school. So, where are they? I think more of it's about where is the messaging coming from than the message itself. But absolutely, different languages are 100% a must to be able to reach everyone.
Great. Joe, do you have
Yes.
things to add?
So there is definitely some evidence that essentially tailoring messages to different populations can be helpful. Often we think about messaging as either generic, kind of targeted to a certain group, or tailored to an individual. And there's definitely evidence that demonstrates that more targeted and more tailored messages can actually have an impact for reaching some of our highest risk groups. I believe that is one of the benefits of a patient navigator who can actually help to individualize messaging to various communities. There is just myriad data in support of community health workers and patient navigators for being able to reach diverse communities.
And just even just to add to that, we started screening obviously at 50 before, right? But patients weren't coming at 50. So now we have to be smart as well. We might be starting at 45, but the conversations need to start earlier. You need to start talking to them at 40. By the time you reach 45, so get them used to that messaging because there's always a delay in the time period for people to come. So not only how we speak to them, where we speak to them, but even when. We need to be very smart about that as well.
Great. All right, so we're in the last minute. So for all the audience, if you're still hanging on, there's some great resources and websites in the chat. I certainly plan to click and save some of these. So please browse through. So in the last minute, last thoughts from both Felice and Joe. Felice, you first.
So what I would say is this, I'm so excited about this change. We've all been waiting for this with, sort of bated breath, and we're finally here. And now what we need to do is nobody knows the answers. When I was preparing for this presentation, I was asking everyone in my division, I was asking my husband, my friends, how would you do this? How would you do this? How do you get our group? How do we do this to actually reach us? That's what we need to do right now. We need to really dig deep, ask those questions, and we can do this.
Great, thank you. Joe?
I like Felice, am incredibly optimistic that we can do this, particularly given C5 and all of our partners on the call here who really recognize the central importance of addressing the social determinants of health and finding ways to increase access, to increase navigation, to really address some of the structural injustices that have really contributed to the disparities that we see, I believe is our way to achieving health equity for colorectal cancer screening.
Well said, both of you, and thank you for your excellent presentations and your thoughts. So with that, we're going to end on a hopeful note. It's March. We're hopefully past the bumps in the pandemic. So let's get to the business of screening and improving health. Thank you so much, everybody, for participating. Thank you, Felice and Joe, for spending time with us and giving us your wonderful advice and expertise. And thank you for everybody for attending on behalf of C5. It was our pleasure and honor to be speaking and discussing this today. There's more information on the website, so please, including a recording of this entire presentation. So please feel free to visit that. And there'll be some more messaging that you'll be seeing coming forth. So please check back frequently. And we look forward to hearing from you. Thank you so much, everyone. Good to see you.
Bye now.
Thank you.